My name is Ken Harrington, PharmD candidate from DUville University, and I'll be presenting a journal club entitled Tiotropium versus Salmeterol for the Prevention of Exacerbations of COPD. The authors are Vogelmeyer, Heder, and Glob, and the article was published in the New England Journal of Medicine in 2011. The reason I chose this article is that I remember studying COPD and pharmacotherapeutics and having some confusion over what was the first-line medications for treatment. The primary objective of this article was to compare the efficacy and safety of treatment with tiotropium 18 micrograms daily versus treatment with salmeterol 50 micrograms twice daily in patients with moderate or severe chronic obstructive pulmonary disease over a one-year period. The primary efficacy measure was overall time to first exacerbation after starting therapy. The study was a randomized, double-blinded, parallel group trial. One group was treated with tiotropium and a placebo, and the other group was treated with salmeterol and a placebo. Neither the doctors nor the patients knew what medication they were on. The inclusion criteria included age greater than 40 years old, forced expiratory volume less than 70%, and a history of at least one exacerbation in the past year leading to treatment with glucocorticoids or antibiotics. And all the patients had to have a 10-pack year smoking history. The exclusion criteria included diagnosis of asthma, active tuberculosis, or cystic fibrosis, hospital admission for heart failure or myocardial infarction within the last year, creatinine clearance less than 50 milliliters per minute, unstable diabetes mellitus, pregnancy, bladder neck obstruction or prostatic hyperplasia, and patients with a COPD exacerbation within the last 4 weeks had to wait until 4 weeks had passed before they could start the study. The study lasted 1 year with a 2-week run-in. For monitoring, patients kept a daily diary, which was reviewed at clinic visits in months 2, 4, 8, and 12, and the patients also took part in a questionnaire at each clinic visit to determine if an exacerbation had taken place. Patients that discontinued prior to 1 year were monitored for vital status alone up to 1 year to verify alive or dead status at the end of the trial. The primary outcome was measured with a modified intent-to-treat population. To be included, patients had to take the first dose of the medication. Power was calculated for the primary outcome measure, time to first exacerbation, with a power of 80% set at 6,800 patients, 3,400 per treatment arm. The type of data was interval, and it was studied using Kaplan-Meier plots, which was an appropriate statistical test. The results of the study showed that tiotropium was superior to salmeterol in reducing exacerbations in both moderate and severe COPD, and that was statistically significant for both of those with a p-value less than 0.001. Tiotropium was also superior to salmeterol in patients that were undergoing glucocorticoid therapy with a statistical significance p-value less than 0.001. And tiotropium reduced the need for antibiotic therapy compared to salmeterol, with a statistical significance with a p-value less than 0.001. As far as tolerability, the most commonly reported adverse event was a COPD exacerbation. Other serious adverse effects included infections such as pneumonia, and that corresponded with a higher incidence in the salmeterol group, which was expected since salmeterol experienced more exacerbations, which is probably what led to the pneumonia. Also, cardiac events and neoplasms were reported, and both were reported more often in the tiotropium group. The author's conclusions were that tiotropium versus salmeterol significantly increased the time to the first moderate or severe exacerbation of COPD and significantly decreased the annual rate of exacerbations among patients with moderate to very severe COPD. The strengths of the study included statistical tests, outcome measures, randomization, dose, duration, inclusion and exclusion criteria, author's conclusion, power, and blinding. There were no major weaknesses for this study, and I gave it a level of evidence of 1. My recommendation is that for patients with moderate to severe COPD that do not have cardiac problems or prostatic hyperplasia, I recommend the use of tiotropium 18 micrograms once daily over salmeterol 50 micrograms twice daily for the prevention of exacerbations. As far as efficacy, the study showed in all patients that tiotropium was more efficacious than salmeterol, and all those values were statistically significant. The trial also reduced the need for antibiotics in the tiotropium group, which is beneficial in preventing the growth of resistant pathogens in the patient. As far as safety, Patients treated with salmeterol experienced higher rates of infection and pneumonia, but it was not statistically significant. Patients treated with tiotropium experienced higher rates of cardiac problems and neoplasms, and this should be a major concern for specific patients. The financial cost of tiotropium was $261.99 per month supply versus salmeterol, $180.99 per month supply, and that's a pretty considerable cost if the patient doesn't have insurance that will cover those medications. Other costs include increased lengths of stays in hospitals for exacerbations, and hospital stays can be upwards of $1,000 a day. So overall, considering the reduction in number of exacerbations, which would lead to less hospital stays, it seems to me that it would be considerably cheaper to be on tiotropium versus salmeterol. For special considerations of populations, I really don't think that the trial, in the journal article itself, the authors didn't talk enough about prostatic hyperplasia and cardiac issues, and didn't talk about that group specifically in their recommendation. They just recommended tiotropium over salmeterol in general, but I think that a doctor prescribing this needs to take that highly into consideration, the increased rate of cardiac problems and neoplasms, even though part of the exclusion criteria was to take out patients with cardiac histories or prostatic hyperplasia or bladder neck obstruction. And that's why in my recommendation, I recommend it for patients without cardiac problems and without prostatic hyperplasia.